Thank you all for being here today. Again, I am Bob Dudzinski, Executive Vice President of the Healthcare Practice at West Corporation. I'm going to take a little different slant today to kind of close out the conference. But really, the essence and the journey of the talk will be around this. I think we can all agree the importance and relevance of remote monitoring. But I think I'm going to make the argument today that remote monitoring is really a channel of communication, a very important and relevant channel of communication, but also it should be a part and parcel to a unified healthcare communication environment. Really an environment that is omni-channel, preference managed, contextually aware, rich in content, and we'll talk about that today. Also, I'd like to align you a little bit with our thinking as we're in the marketplace. So, and there's so many topics today that are intertwined between these three summits, but let me just start by saying how we think of population health management really is a tool that was designed to acknowledge and respond to the transformational changes that are occurring in healthcare. It really is a systematic approach to managing preventive and chronic care challenges of patients. It's meant to mitigate risk, it's meant to lower costs, meant to improve outcomes. How we see telehealth is really part of that tool. Telemedicine encompasses diagnosis, oftentimes treatment, but you add evaluation, monitoring, and all of a sudden you've encompassed telehealth. As we look at telehealth, we define it in really four domains, not far from what Mario spoke to today. We see the domains of synchronous communication. Video consult often comes into mind there. We also think of voice as synchronous communication. We think of asynchronous communication as a domain. So again, things you heard from Dr. Malt yesterday, also things like email fall in that category as well. We consider remote monitoring devices a domain, and finally health. So the real question becomes, is all of these domains to us are channels of communication. How will we as an organization, how will we as a collective healthcare entities and systems aggregate, integrate those changes, those channels of communication, and really drive an enhanced patient experience? And why are we interested in enhanced patient experience? Because ultimately we're going to get reimbursed on that. So again, it becomes very important that the assessment of this becomes how do we develop an engagement and an activation strategy around integrating all of the channels of communication for our patients. So again, and to put my comments into a little bit more context, I'd like to take just a moment to tell you a little bit about West. We're publicly traded. We're about 12,000 employees worldwide. We participate in about every segment of healthcare. So probably some of the more inconspicuous ways that we participate is if any of you have gone to CVS Caremark and gotten a refill reminder, you've gotten that from West. If you've been on a conference call, you most likely use our technology. If you were in the other sessions, someone raised their hand or the speaker talked about, does anybody in healthcare have an experience like American Express does theirs? The backbone of American Express's experience is West technology. If Medicare had a conference call with 29,000 participants, they generated 1.7 million minutes. That was on a West platform. And so again, we have a significant footprint in healthcare, and today again we'll talk about the importance of engagement and activation. So again, question, no one needs to raise their hand, but how many of you have a remote monitoring program in place today? And then how many believe that you've successfully integrated that program into an overall patient engagement strategy? How many of you have an engagement strategy that speaks to how you will approach healthcare reform, the Affordable Care Act, and really kind of the buzzword we heard today, which is really consumerism. Somebody asked me, how would you draw healthcare communications today. And so we took a stab at that. And really how we see it today is oftentimes patient to the left, out of center, one-dimensional, linear in its disposition, the need to connect a variety of different nodal activities that all constitute the continuum of care. So again, this is how we depict a lot of healthcare communications today. Where do we think it needs to be? And this you've heard all day today. Patient needs to be centric. Constituencies need to be connected. Data needs to flow seamlessly. Channels of communication need to recognize and be aware of each other and be real time. Let me just spend a couple of minutes talking about an engagement strategy and what we are seeing across the country in health systems, in health plans, in pharmacies, in pharma. There's new titles emerging. VP of Patient Engagement, VP of Patient Experience. So oftentimes, what does that really mean? And I would make the argument that it will ultimately mean that the aggregation of communication channels will be ultimately important to drive a consumer-like experience in the marketplace for our patients. And so how do we go about doing that? First of all, we get the stakeholders together, and we vision and goal set and define our objectives. I was asked, what does it mean to vision around engagement strategy? And I guess the simplest way to put that is, picture yourself as a patient. How would you like to be engaged? What would be your expectations? How seamless would you want it to be? And that starts to outline your vision with respect to patient engagement. It becomes important that the constituency associated, the stakeholders, the organization fosters a culture of patient engagement. That becomes critically important. I'll talk about a case study here a little bit later on, and really how we sat in a room with 43 people in a health system talking about healthcare reform, the Affordable Care Act, and what it meant to them from a consumerism perspective, and how consumerism was directly linked to an enhanced patient experience. I think we also, too, have to recognize we are pushing this on patients. We're asking them to be consumers. And if you haven't seen some of the latest studies, 84% of patients would switch providers based on the amount they pay. 24% of that, 84%, would do it for less than $30. So again, we are educating, we're asking the patients to become consumers, we're asking them to engage with us, we're asking them to be accountable as we move into healthcare. And then finally, another part of the strategy clearly is to monitor, measure, and adapt. That's nothing new. So we need to understand where it is, where it's going, and what we need to do to modify and be successful. Today, I'm going to challenge a couple of the comments that were made throughout some of these presentations. Not say that they're wrong, but I will also speak to how maybe we need to think a little bit differently as we approach a strategy inside of healthcare for engaging the patient. A couple of examples of that. Oftentimes, from a remote monitoring perspective, we talk about that 20% that's creating 80% of the cost. No doubt. No doubt. But should there not be a program that addresses the 80% before they become the 20%? And can you do that at scale and capacity to make it affordable? I think the answer, we feel the answer is yes. So, saw an interesting quote the other day, a gentleman by the name of Leonard Kish, and he was blogging on an HL7 blog, and actually Forbes picked it up. Basically what he said is that patient engagement is the next blockbuster drug of the century, and it would be malpractice not to use it. So again, a little bit different take on how he's approaching the world. So, putting remote monitoring into context, we know that remote monitoring is driving promising outcomes. But could those outcomes be significantly greater if we were able to integrate those into an overall patient engagement strategy? And could we actually drive greater utility from remote monitoring could we create a greater ROI if it was integrated into an omni-channel, unified healthcare communication environment. Dr. Mull talked about this a little bit yesterday as well. What's the impact of a disconnected patient? He talked about healthcare being disconnected, unaffordable, linear, not connected. I think we all often talk about that. But again, in the context of engagement, when we have a disconnected patient, what happens is that patient engagement efforts often are removed in departmental initiatives around discrete goals. This is what we see historically around health systems. You have a telemedicine initiative in this department. You have an organization that's trying to fix their call center or their access center. You have a care coordination program happening over here, and none of those initiatives have been folded into an overall engagement strategy. So again, when we don't put the patient at the center, then this typically is what happens. Poor patient experience. Lack of channel choice and continuity between touch points. We know that the patient's going to be getting touched more and more often. And we use a term in our world called preference management. And really what that's all about is patients often choose or would like to choose how and when they would like to be contacted. A comment was made earlier that, and I know who made it, the guy right over there, said, if an IVR called me, I'd hang up on it. I would make the argument that I would give the patient a choice as to whether or not the IVR should make that call. And I would give the choice to the patient whether or not they should be on a remote monitoring device. I would give the choice to the patient whether they want their mobile phone to play a very instrumental function in contacting them. So that's how we engage, and that's how we talk about preference management. It becomes a very important part of the overall strategy. When you have a disconnected patient, you have suboptimal outcomes, nothing new there. And then clearly inefficiency, inefficiency, and inefficiency. You know, there was a lot of program discussion throughout the last couple of days here around care coordination program, population health management programs, some being extremely successful. But I think the one thing that was very interesting in all of them is great success when the population was 29 or 50 or 100 people. How are you going to do that when you have tens of thousands or millions? How will you bring scale and capacity to the engagement process for that particular group of patients? And we'll talk a little bit about this, and we'll see some, again, when we get to the case study, we'll talk about a population that we're managing of 100,000 Medicare recipients and how we have moved their nurse-to-patient ratio from 150 to 1,200. And why we will make the argument that by doing that, we're actually delivering better care. We're lowering the overall cost of care, and we're lowering the overall cost of administration. So we'll talk about that in a little bit. Why is communication so difficult in healthcare? Again, to kind of put this, and I think you all know this, but to put this statistic in perspective, 11,478 of us are going to turn 65 today. 92% of us are going to have a chronic condition of that population. 77% of us are going to have two chronic conditions associated with this. When we get to 65, we're going to average about 14 prescriptions every year. So we're hustling down that track for expenditures. We're having more patient touch points, whether it be the Apple, whether it be Qualcomm's initiative, whether it be an IVR system, a texting system, there will be more touch points engaging on the patient. And obviously we don't think that is getting bigger. We have a lack of standardized processes and workflows, and we have technological and cultural hurdles. I want to talk about that for just a minute. We have a human factors division at West, and oftentimes when we engage an organization, we will do roundtables with either the care coordinators and the patients. And as would be expected, when we sat down with the nurse care coordinators, there was a great deal of aversion towards technology. And what their challenge was is that they feel they needed to take care of that patient technology could not be a substitute for what they did. And there was a great deal of discomfort around utilizing an omnichannel approach to managing this particular population. And as we went through, as we talked a little bit about that, and we started to dissect the difference between care and tasks, and how we can provision, how we can automate tasks to better provision care, we started to get buy-in from the nurse coordinators in that particular workshop. So what exactly did that mean? Something like this. We went down this path and we explained to them that every day when they're making those phone calls to those patients, they love that. But oftentimes you're talking about other things. You're talking about the pizza, you're talking about the Super Bowl. How is it? What you really need is you need that biometric reading. And you want to establish that for your most risky patients every day. So how this group of care coordinators will start with is they actually enroll the patient in the program, they have a piece of paper, before we go home, take a blood pressure reading, do it every day, twice a day, and then after 2 weeks, mail it in. There's a little bit of latency associated with that, clearly. So what we did is we said, what if we could automate that task simply? And what if you could utilize that time to look at the top of your license and put that time? So what we basically did is, what we do today, is we consume those risk stratified patients and where they have a preference to be proactively notified. And we do that with an outbound IVR system, where we actually call them, drive personalization, allow them to speak their blood pressure readings in. We decision on that from a standpoint of high level. And then present that payload back to the HR system and on the desktop of the care coordinator. In addition to that, we overlay technology that said if that does exceed a certain threshold, we'll connect you back to your prescribed care coordinator, not to a pool, but to a defined care coordinator. So again, when we explained that scenario to the nurse, that became exciting because she felt that she could take care of more patients more often and really start to look at the top of her license. A little bit more time on what a unified healthcare communication environment is by definition. Really what it is a highly integrated communication environment that really unifies all the channels of communication, which includes text and voice and video and data, really in ways to drive greater continuity, create a better experience, and improve process and productivity, and all towards driving a better outcome. With a unified healthcare communication environment, we can drive patient-centeredness. We'll take an omni-channel approach. We'll support the notion of the care continuum, and we'll incorporate work care plans and business processes more effectively. Interestingly enough, what we're hearing out there is that, and what a UPC supports, is strategies that are kind of focused on the patient imperative today that we constantly hear, which is, and it's interesting because this was a rallying cry for one of our health systems. They actually formed committees around this saying, know me, show me that you know me, and show me that you care all about me. And that was their approach to developing an engagement and activation strategy. And really what that meant is that they were all about stratifying the patient, understanding the patient, giving them relevant and pertinent information, and allowing them to choose how best to engage the health system and the doctor. I know a lot of you have seen things like this. I'm just going to take a moment and play you a video. The video will show a remote monitoring device integrated into a platform where when a certain threshold was met, then we also simultaneously text a physician. Not a great thing, but I think it's a illustrate what it means to have a multi-channel environment. So hopefully this will work.
I used to be able to get away with skipping my exercise for the day or maybe not following my diet as closely as I should. I mean, who would know, right? Well, Melinda, my nurse care coordinator, always knows. Last week when my blood pressure cuff set my readings wirelessly, I guess they were too high. Within 20 minutes, Melinda called. And when I saw my doctor today, he knew too. He said he got a text message from the My Care Coordinator system when my readings were high. Before they had the My Care Coordinator system, I got away with a lot more. But I'm healthier now, and I'm happy about that.
So with that, I want to talk a little bit more about a case study. And to kind of put this client in perspective, Academic Medical Center, the lead organization behind an accountable care organization. We engaged them about 2 years ago. 43 of us met at their organization, and we sat down and really wanted to talk about healthcare reform, the implementation of the Affordable Care Act, and what it meant where consumerism played a role in this. What they clearly understood is that they were heading into an environment where they will be charged with managing patients outside of their four walls. And you've heard that 100.5 times. But again, they needed a strategy and an infrastructure around that. So 43 of us sat in a room, and probably the biggest challenge that we had was where to start. And what we decided on was they had a population of about 100,000 Medicare recipients. And we thought that would be a satisfactory population to begin and developing really a goal, which was to demonstrate the impact of an integrated, automated, and human-in-the-loop patient communication on the aggregate patient costs for a targeted population. And so that's where the journey began with this particular health system. So, as I spoke to earlier, our first effort was really to sit down and, with our human factors division, go and have patient roundtables and care coordinator roundtables. You heard a little of the results of the care coordination roundtables. On the patient side, probably one of the more interesting things, comments that came out of that particular roundtable was we had a patient actually stand up and say, I would rather walk to this institution than I would call, because it is horrendous. And that kind of set the tone for the challenges that we had before us. So, where we started then is, like any population health management initiative around care coordination, they took an approach where they had a platform. They aggregated their data, their clinical and their claims data. They went through a risk stratification process where they identified disease state and level of risk acuity. To that, they assigned care coordinators, which had protocols, or actually had plans of care. But inside those plans of care, they had protocols. Inside those protocols, there were defined interventions that they wanted to engage in. So getting back to that very simplistic example, what they recognized that they had a significant population of high-risk hypertensive patients. And so what their protocol called for is for that particular 1A population was to acquire those biometrics, blood pressure readings, along with weight and pulse every day, twice a day. So again, they went through an educational process, and those people consented to participate in this. And I want to digress for just a minute. If any of you are considering utilizing smartphones for any type of communication initiative, consent, explicit consent, is critical. In fact, explicit consent held this particular program off. And we'll talk about that later, but what that meant is that group of patients chose to be proactively notified every day, twice a day. Now that we segmented from there, some wanted to be able to call in their blood pressure readings, some wanted to use a remote monitoring device, some wanted to be text when they should call in. So we had a myriad of channels that we were providing for that particular group of patients. So again, to get a little bit more granular, in the case of an outbound proactive IVR system, the message was sent out, patient acknowledged it, we did authentication, we actually did some work on the ANI, the phone number that was presented, we actually made it up the health system. In some cases, we've been all the way down to the doctor displaying on the phone. Patient could put their blood pressure readings in, we would decision. So in other words, if it was high, then we could connect that patient immediately to a care coordinator. Otherwise, that intervention came up on the desktop of the care coordinator and then ultimately was promoted to a dose epic, and then at some point it was promoted to the epic system. But those interventions then were identified and organized and placed inside of their EHR. So that became kind of the basis of the program. Really what they were trying to achieve was efficiency of the care coordination by 100%. They wanted to have more speed, frequency, and reach of those interventions. They wanted biometric acquisition and journaling through remote monitoring devices and through other channels of communication. They wanted to increase the number of patients receiving these services. And they really wanted their care coordinators to spend more time on their high-risk patients. They wanted the care coordinators dealing with those issues rather than taking the phone call and reminding a patient about some task that they needed to perform. Let me give you another example of where this might be applicable. You heard from Centura, Colorado. They had a tuck-in program, and they had a Call Me First program. They did that on a Friday. I thought that was great. A nurse executed that. I think to do that type of intervention at scale and capacity becomes imperative. And so, as an example, to do it for a population of 2,000, where you've stratified those by medication, how are you going to do that for a minute? And I think those types of tasks, where it may not necessarily rise to the level of care, where we can automate that, really starts to drive, I think, more of an engagement, can change a behavior, and improve an outcome. So again, we went through this process. We started in our care coordination program, and then as this technology got exposed to the rest of the organization, we went down a path of how do we then take this success and make it applicable to their access centers. And their access centers, by their definition, was really the 23 pods of their health system, which was really the call centers, where each pod had a different set of business rules and objectives of how they would answer a phone call. And so again, as we looked at the transition from a care coordination program to how we could help them go through access center transformation, start to deliver the same world-class type of call center activities that organizations like American Express, Bank of America, Sallie Mae, Alaska Airlines do it, we could transition that to that particular health system. We also then, they had an initiative where this continued to migrate to, is they had an initiative around member acquisition, member retention for their ACO marketplace. And they needed infrastructure in order to be able to communicate with disparate systems effectively. So one of the technologies that we're deploying is our virtual care center. So we actually have a platform that its genesis was a virtual event center. So picture this conference as an example, being virtualized on a portal where you could actually go to a booth out there and chat with the vendor, have the ability to aggregate your collateral material, have all the video webcasts being available to you, and then have it avatar green. And so what we have done is we have curated that platform to be part of their tool that they use for ACO member acquisition, retention, and management. So what they're doing today is we've actually placed the chairman of the board as an avatar in the virtual environment. He actually welcomes the membership of the ACO. He drives localization. So we actually virtualized the regional medical directors inside the environment. And we allowed the chairman at that level below to do real-time webcasts and be a repository of information as they went through a process of retaining, managing, and acquiring membership. We now have purposed that platform into a telehealth, telemedicine initiative where we have intimately linked educational services to video consults. And so in an environment where the patient can come and go through an educational process, well organized, maybe even awards driven, but simultaneously within the same environment have a virtual consult and also have the ability to do an asynchronous communication. Take a picture, store it, forward it to a primary care doc. So our mantra along those lines has always been that with respect to telemedicine, we've often taken the position that it should be part and parcel to the overall workflow process of primary care. It shouldn't be a remote solution, or I should say a point solution, or a solution disconnected from the care continuum. It ought to be part and parcel to the overall process. This next slide really speaks to kind of the approach that we took back to the call center work for this particular health system. And really what they were doing from that perspective is they wanted to drive operational efficiencies and effectiveness. And again, the idea and the notion of creating a better provider and patient experience was clearly on the top of their minds. So again, we went through a process by which we could help them take this particular journey. Where do you start? This is our recommendation. Drink a little wine. Drink more wine, wait a bit, and have one more glass. That's our force of conduct. You know, when I first put this slide in, a lot of people laughed at my comments. Thank you. Thank you.
That's where we're going.
Right after. Now, I'm trying. So, just a comment on this. Really, what we do is we have an engagement and assessment process. It's 4-step methodology, and some of you have already exercised it probably internally, whether you know it or not. But it really goes. It's very simple. It goes like this: we put the stakeholders in a room. We vision with them. We understand what they think patient engagement and activation ought to be. Number 2, we take an inventory of the current telephonic assets and also their human resources. We talked about that human factors division, doing roundtables with care coordinators and patients. Thirdly, then, you must develop a business case. And that business case must have a powerful enough ROI to make sense. And then finally, we help them develop a roadmap. So what is the art of what's possible is what we display in that final piece of that assessment. And again, where we come from in that perspective is, and I mentioned this earlier, we do about $500 million of work in healthcare, but almost 4 times more of that outside of healthcare. And so what our non-healthcare clients have asked us to do is to create a better consumer engagement. So the likes of Apple, Bank of America, Waste Management, Alaska Airlines are all clients of ours. And so what we do when we develop and work with the health system is we show them what other industries have done to bring state-of-the-art, world-class communication technologies can do and will do. So with that, how will you know you've achieved a unified healthcare environment? And this is just really a recap. Number 1, it's certainly patient-centered, omni-channel approach, bi-directional, proactive, personalized, and there's a seamless integration into the human assets that always exist in an organization. So how can we provision communication technologies to better provision care to the actual patient? Should it be based on evidence-based medicine, disease-specific? What is its relationship to the care plans that have been developed? How do you execute on protocols that have been put in place? How can you augment them? How can you bring fuel to that notion of population health management? I would make the argument that a successful engagement activation strategy addresses all patients. We've talked about this today, and clearly remote monitoring against the most costly patients make great sense. But I also would make the argument that there should be a strategy for those that don't quite need that level of care, but need to be in the loop and need to be connected. Got to be able to do this at scale and capacity. You have to take an approach that separates tasks versus care. Probably became most relevant to this health system that was in the case study when they recognized that we operate about 200,000 IVR ports. So we can touch 100,000, all of those patients within 3 seconds, simultaneously at the same time. And so that became very impactful to them, because that got the wheels turning about what they could do with that type of scale and capacity. So again, I think it's important to vision to a level that the organization feels comfortable with, and there isn't a degradation of the care imperatives that the organization has. And then finally, I think it's also very important to be able to leverage the investments that you already have made, whether those are communication investments or whether you have recently invested in a population health management platform from some vendor. It will be critically important that all of those assets be inventoried and leveraged in a collective strategy around engaging and activating the patient. So when these attributes are met, get a whole lot closer to a unified healthcare communication environment. So with that, we are done. I'd be happy to answer questions.